All right, everyone, we're going to get started. I'm Dr. Hira. I'm the chief medical resident that has the pleasure of introducing our grand round speaker today. Professor Rosario Isasi is the director of the Institute of Bioethics and Health Policy at the University of Miami. She is also associate professor for the Department of Human Genetics and adjunct professor at the School of Law. She is also affiliated with the Husman Institute for Human Genomics and the Interdisciplinary Stem Cell Institute. Professor Isasi is an internationally recognized scholar whose work examines ethical, legal, and policy dimensions of emerging biotechnologies. This includes precision medicine, genomics, regenerative medicine, and artificial intelligence. Professor Isasi has obtained international recognition for her work. She holds multiple leadership roles in ethics committees for stem cell and genetic research. Please welcome Dr. Isasi.
Thank you very much for the kind invitation. It's very rewarding to see so many familiar faces. And also, as some of you have been my healthcare providers, I feel very trustworthy on the ethics of your practice, I should say that. So today I want to talk about ethical challenge in using AI in clinical care, how it might affect, what are the downsides of using AI, and what are the benefits, and how, if something I want to impart to you, the importance of interdisciplinary collaboration to support responsible AI and innovation. So I don't have to tell this audience what AI is. Let's just agree that it's an umbrella terms that bring together a number of tools that that perform functions that normally we identify as human intelligence. So what is already here? We hear a lot about how it's going to transform healthcare. It's already transforming it. You will be familiar with using an ML and NLP and generative AI, using risk models, documentation, and patient apps. The idea here is to really focus on what are the real world functions of AI in healthcare, and what is the ethical and social dimension that goes pair and pair. The promise, we know, we want more accuracy, efficiency, early detection. We want to provide better healthcare. But it comes with a paradox, right? As we do that, we bring opacity in reasoning. We create biases that taints our outcomes. And sometimes we over-rely on tools and forget about accountability. So what makes AI ethical? Probably you have heard a lot about ethical AI. First, AI is not ethical or morally neutral. Why? Because the whole AI life cycle, from idea development to implementation, what happens in between? Human choices. And those human choices have a systemic impact. What problems do we solve with that tool? What data do we use? What outcomes do we prioritize? But very important, who are we benefiting? And by benefiting a sector of the population, we have to think, who are we leaving behind? Who will we be harming? What are the systemic effects? Are we impacting then down the road health disparities? So technical decisions shape this. Who is overlooked? Complexity and opacity, I'm going to keep mentioning because it's a theme. It cross-cuts different AI applications, obscures responsibility. It might limit accountability. So the idea is, as everything about ethics, being prospective. Start to build it from the start and then know when there's harm. Ethics is not harm reduction. It can mitigate harms if you include it since the beginning. So ethics is a pillar, is the legitimacy infrastructure that make AI adoption publicly defensible. So when we talk about ethics in AI in healthcare, the majority of people, what they think? The system works, right? It must be ethical, it's working well. We are following the rules. Ethics, morality, social choices are not just technical. It's not about the technical aspects of AI are obviously crucially important, but we cannot forget the ethical dimension. And when we talk about ethical dimension, probably some of you are really kind of even bored every time we list ethicists a number of ethical principles, right? Look at your CD training and others. The problem is we don't translate them in real practice. These ethical principles come to life in real life, in the world. How they come to life when we operationalize it. So there are moral guardrails, and they prompt us to see how an AI tool, an AI system is really providing better health and for whom. So that it respects autonomy and agency, that it distributes fairly the benefits and the harms. It is trustworthy. And this is not easy. This is not ethics on the cloud. This is in the real world. It's messy. It's difficult because ethical principles, as life choices, sometimes provide dilemmas. Sometimes they collide. Sometimes we don't agree on how they interpret it, how we implement it, how do we evaluate it. And in life, there's always trade-offs. The issue is when those trade-offs forget the ethical scrutiny and we don't track performance. We don't track harms. We don't trust responsibility. And we suddenly becomes with what? Flawed knowledge, flawed tools that are normalized, they're routinized, that creates problems in metrics, in oversight, and implementation. So if we're going to build a framework for ethics in AI, we require ownership, metrics, monitoring, and importantly, redress when not principles alone. So I want to propose a very simple, grounded framework for analysis. And this functions in this domain. This is where the real ethics work happens. And the three domains are very simple, intuitive. The ethics of knowledge. So where the knowing, where is the knowledge coming from? Had it been validated? Which populations are there mining and producing the data or the tools you are mining? And once that knowledge, once the AI have that output, how we act upon it, who's responsible, what we owe to others. And finally, when I talk about the ethics of governance, it's really about responsibility in the whole chain of stakeholders. It's about accountability. So these three domains, very practical, they're interdependent. One has like a cascade effect on the other. If the knowledge is imperfect, if there's information on failures, it will create uncertainty. And uncertainty about the choices as a reasonable, prudent physicians you will employ them. And that uncertainty will create governance gap. Did we monitor? Did everybody check what it was implemented? Did everybody check that the AI tool was drifting? Did everybody check that we over-rely? And then it produced harm. So let's talk in a practical way. What is this, the ethics of knowing? They call it epistemology. That's a fancy term to just say the quality control system for knowledge, for what we know. So AI shifts medicine, you all will agree, I think with me, from causal reasoning. How is that causal reasoning when you learn? I come from a family of physicians, so I would say physiology, right? What else? Evidence, and most importantly, your experience. So this causal reasoning, that body of evidence we have built, how we practice medicine, suddenly start changing, or there's this push to change toward a statistical prediction, right? So probabilities, but a model could be incredibly predictive and really good, but it's different and it's not the same that understanding if it's opacity, if you cannot interpret the finding. And then there's the issue of trust. And trust is not this aspirational goal, idealistic. It's really about uptake. Will physicians trust the system they want to use? Will your institution trust and want to employ these AI tools you really want to apply in your practice, right? And then society. So some of the basic key questions is, if the knowledge is accurate, okay, but for whom? If there's limit on this knowledge, where did it come from, right? What happened if it fails? If there was any missing data? So again, knowledge failures aren't just technical, they become ethical. This is ethics in practice when acted or in care. So bias, the number one probably case, if I ask you, what are the main problems with AI? Bias. Bias is important because it's preventable harm. And ethics comes a big role since the beginning and try to bring bias for maybe we cannot completely eliminate it. The issue is to mitigate it, to recognize it, and to deal with it. So bias leads to misdiagnosis, some of the harms, and the referral and safe care. Think about where your data come from. Skew data sets, poor representation. What happened with the algorithms you're using? Are there label errors? What happened with your cohort? Are there model drifts? And then let's think of a two perspective. It's not only about the clinician and always blaming that, oh, it's automation bias, that problems feedback. Look for the patient's perspectives and operate in an area where there's literacy gaps, where there's mistrust in science and imagining novel disruptive technologies, and also the privilege of bias. So the core message here about bias is that it could be mitigated and it could be, if cannot be prevented. Transparency and explainability is another one important thing. So what are the tools' purpose and what are the limits? We think about black boxes, right? And black boxes, the problem is, hey, it's opacity, we don't know. And they affect shared decision-making. So both clinicians and patients deserve to know what the system does, how it's working, and why it made a recommendation, and requires interactive scrutiny to see whether that recommendation is still valid for that particular patient in that particular context. So ask questions about how it was trained, how it was validated, etc. And there's a number of principles that become the anchor, right? Welfare, avoid harm, build trust, promise redress, agency, autonomy in the patient-doctor relationship. Reproducibility and validity are also common problems. Reproducibility protects the integrity of the data, whereas validity protects what? The integrity of the patient, safety. So if AI can be independently verified, then trust becomes just guessing work, right? So the questions, like in any area of science, we always ask, could we verify the evidence? Could we validate it? But in AI, there's always problems with proprietary data and closed code that often block transparency. So, and that could create systemic errors. In terms of validity, does it work for your patient in your setting, as I said before, right? It is fairly applicable and requires, as I said before, diverse data, but also real-world testing. So let's bring back to the real world again and with a case example. So Dr. Lopez, a family physician in a busy urban clinic, uses a new AI-based risk calculator to identify patients at high risk of developing type 2 diabetes. So Mr. Akande, a 52-year-old Nigerian immigrant with a BMI of 31, borderline A1C, and a family history of diabetes, is flagged as low risk. Trusting the tool, Dr. Lopez offered routine follow-up rather than referring him to the clinic's diabetes prevention program. Okay. A year later, Mr. Akade returns, but this time he has symptomatic hyperglycemia and is diagnosed with diabetes. So here, what is the issue? Probably it's very obvious for you right now. The treating AI-generated knowledge, the physician treated this AI-generated knowledge as universally valid without questioning whether it was relevant for the diverse patient population. And something I'm going to repeat, an AI tool will be very valid in one hospital, will work beautiful in one hospital. But the question is the patient population the same? Are the workflow systems the same? Are we monitoring the same way? So some of the discussion prompts that I will ask is, well, the model was validated, right? What questions should the clinicians ask before employing the tool? Do we recognize when a model accuracy may not be applied to our panels, right? And one of the issues is when we take this AI knowledge as authoritative. The ethics is doing, so we talk about where the knowledge comes from, where the AI output comes. So what happens now? How do we act upon what we owe to others, how we act responsibly with that knowledge that could be imperfect? So the challenge will be One of them is informed consent, right? Can we promote understanding? Can we promote really agency, balancing of benefits and risk? Can we prevent harms by this over-reliance, and can we try to improve outcomes? So AI can support care, but it cannot replace moral responsibility. Autonomy for consent, many of you, we can spend to eternity talking about whether informed consent could really live up to the four elements. It was really always comprehensive. It was always voluntary. It was always understanding, right? But the issue here is a minimum. Can the patient understand how it works? Do you disclose the use of AI? I have been in practice and suddenly I realized, not here, but I realized that there was an AI tool. And I was looking, when they want to tell me that this tool is acting as described, if they know where I work and who I am, they will ask him and fully consent me, and they kind of nervous as if I'm the ethics police. But other times, and I play this exercise with the doctors. This is so, or they tell, this is so cool. Could you tell me about how it is, how it represented? Have a wonderful talk with somebody in dermatology that was explaining about this relational aspect and how for him, in certain patients like me with this skin color, with family history, etc., his tool might not work enough. So that's consent. But black box systems limit decision making. The idea of all informed consent is shared decision making. But in AI evolves. Consent today might not cover tomorrow's use. So we have to try to start guardrails and how data is used, how it's reused, how we can try to improve language explanation, etc. I'm a lawyer, and I tell you, every time I read a consent form, particularly for research, I really think I'm reading a contract with disclosures instead of a document that helps me work on a process, in a process for understanding choice. Why the research participant, what the patient is choosing that? Can I protect them in a way that is not paternalistic in the wrong way? So benefits and justice. Here is really how we promote welfare. I said it before, AI is supposed to improve healthcare. And then my question always is gonna be redundant. It's gonna say, for whom, under which conditions? Can improve diagnosis, treatment, and outcome, and share benefits. But for that, there's some questions that remain, right? AI is only ethical acceptable if it improves welfare without concentrating harm and excluding people from care. And I'm gonna give you some examples from that. I'm just quickly gonna work towards address non-maleficence and trustworthiness is how we avoid harms that could cause for, think about the whole life cycle of an AI tool. If somebody developed it, a vendor sold it, an institution bought it, a clinician implemented, a patient received it. So where is the harm could be? Is in the misclassification, in a hidden variance, on the moderate risks, etc. So think about these core elements, and importantly, build trust. What it really means, trustworthy AI, is that you trust the tool you're employing and your patient trusts you. That relational human aspect that no tool, no technology should ever replace. So this is one of them, one case. Nguyen, a second-year resident, is using this new AI documentation tool that drafts visit notes and suggests care plans. During a follow-up visit, the AI recommends increasing Mrs. Caldwell's antihypertensive dose and a scheduled 6-month follow-up. Dr. Nguyen is running behind, assess the plan without discussion. Mrs. Caldwell, a 68-year-old woman with mild cognitive impairment, later experienced dizziness and falls. She tells the nurse she didn't understand why her medication was changed and thought just the computer make the decision. So this is the typical case of automatism variance and erosion of shared decision-making. You may argue that doctor didn't act like a reasonable, prudent physician, didn't fulfill the care because anybody, but we live in a real life and we have efficiency pressures. We get excited with the hype of technologies. And actually, I built this case for an anecdote of a doctor. And I use AI to blind it, by the way. So one is principle, how we keep maintaining judgment with AI tools are the risk of over-relying and generating tools, so we give them so much authority that they deserve. Let's try another example. This is the ice case. Dr. Reyes, a faculty physician in family medicine, resident clinic, is part of these pilot programs, replacing human scribe with AI-powered ambient documentation system. The tool listens to patients' visits, generates the OSAP's notes, and integrates them into the HR. Sounds familiar for some of you, probably. Dr. Reyes appreciates the efficiency, no more waiting for scribe availabilities. Notes are ready by the end of the visit. But over the time, she noticed subtle shifts. The eye sometimes misskips psychological details, like a patient recent eviction or a sudden expression of domestic stress that her human scribe used to be very good in catching and flag. The resident begins to rely heavily on the eye-generated notes, rarely viewing or editing them. That we get automated, right? Automated work. So this Mr. Delgado, a Spanish-speaking man with limited literacy, later complains that his visit summary includes a medication that he never agreed to start. The eye had misinterpreted that discussion as a decision, and no one caught the error. Again, cases that come sometimes from real life, and we can argue again, but hey, Rosie, we don't act like that. We are very professional, we're very responsible. Hey, but we are human. So the ethics of governing, how AI will change systems. So AI doesn't just appear overnight, right? As I said before, it's chosen, it's deployed, it's maintained. But a lot of times this governance that should turn values into action fails. So the quick question to here is to say, who in the supply chain approved the tool? And based on what evidence? Is somebody monitoring? Is somebody triggering? If there's a trigger, decides to pause it? Is somebody accountable if harms occurs? And there's harms that could be very tangible and harms that will not tangible. Dignitary harms, for example. Erosion of trust, the patient didn't understand and then thinks this machine is replacing the doctor, just fulfilling more mistrust in science. So what patient and clinician can challenge AI divisions? And what is important, government failures, because it will take us at the end in institutional risk. Like AI affects care, coverage, and access. Don't think only in care, think in other aspects that are behind. Without governance, they might become more systemic, they may become regionalized, and they will be harder to challenge. So what it means is really always create this traceable system. And the main question here will be, should AI in healthcare be held accountable in a human-like manner, or whether humans should always be the only actors who are ultimately responsible? So own it. Who relied, when and why, document it, and go back for the institution if a safety review and incident learning is telling you that things should change. Public engagement. What I really want to tell here is that public engagement, what it really is incorporating values, social values, into decision-making. And engagement is always forgotten as, it's thought as one-way tool, right? We bring people to the table, they may not have a voice, but are sitting there. It's a two-way accountability tool. Communities have also a role, those patients' perception. They must shape, not just receive AI governance. So it has to be inclusive, but inclusive means caregivers, community, and the technologies themselves. So when it could put engagement that could lead to mistrust, could be a lower uptake. If we perceive that there's misuse or there's secrecy, if there's, this will stall adoption, right? And erosion of legitimacy. And could harm not only the patients, but also the institution, the damage to the institution. There's a lot of structural and societal risks that always arise. We have heard about workplace disruption, scribes saying, I'm gonna lose my job forever, and other aspects. Here, I just wanna capture one of the arguments of the concerns about AI, to say it will dehumanize medicine. And I would like to challenge that. I like to challenge that it will never or should never replace relational care, could never replace that empathy, could never replace that we forget to treat the person, not just the condition. And why do I say that? Yeah, you might hear a lot in a lot of lectures. But the issue is, if we rely on AI to categorize, what are the patients now? Your patients might be stratified by low-level risk. They might be stratified by other conditions, right? They became these categories, and categories lead to depersonalizing. So the idea is never replacing the clinical judgment by that level of human empathy. So let's see another example. Sunrise Family Medicine implements an AI scheduling tool to reduce no-show. Very good. We know here, even in our institution, how no-show is a prevalent problem, right? So this leadership or somebody decides in this system to create an algorithm that will deprioritize patients that are recurrently missing appointments. And then what they do, they give them the last slot, right? Just in case they show up. So Maria, 34-year-old Spanish-speaking single mother, who relies on public transportation, is always scheduled at 4:45 the end of the day. Anybody trying to take public transportation in Miami at 4:45, right? So she frequently is running late because the bus is delayed and is always marked as a no-show. So the system keeps putting her at the end of the curve. When she asked why she cannot get an early appointment, the front desk replied, well, it's the system. We have a process for this. Dr. Patel looks at this, he's diligent, he knows that there's have to be oversight and control, and said, you know what? A lot of my patients that come from these zip codes are always pushed to the end of the day. So what is the ethical issue here? Is that there was employment of a system without monitoring systemic impacts. Without monitoring how socially deprived patients might be getting the wrong end of this thing. So when we deploy algorithms, can we detect and prevent algorithm bias, for example, here in scheduling on triage? Do we have ways to redress it? And this is part of the aspect when I said that the human aspect should never be replaced, right? Dr. Patel, if knew his patient, would say, well, Maria maybe is always late or doesn't come up because she has other challenges. And the system is failing her, but not allowing her to really participate. So let's bring a case, my last case, that brings everything together. This ethics of knowing how our knowledge is generating, how it's implemented, and how we act upon it. Dr. Smith works in a family medicine urgent clinic that recently implemented an AI triage tool to streamline patient flow, very common now. The system uses preceding complaints, vitals, and EHR data to assign patients to fast track or full evaluation pathways. So one afternoon, a 45-year-old woman, Mrs. Rivera, presented with fatigue, has mild shortness of breath, vague chest discomfort, but the tool assigns her to the fast track lane because it categorizes, remember the labels, of minor complaint. The resident follows the AI recommendation. It takes us as authoritative, performs a brief exam and said, well, this is a viral illnesses. 2 days later, Mrs. Rivera is admitted to the ED with a non-ST elevation myocardial infarction. An internal review, so this is governance, right? The ethics of knowing where the knowledge came from. In governance, the model was training where? The population was younger. They have commercial, they have good insurance. And it had not been validated for the clinic's largely underinsured population. So the triage algorithm and decision-making process was opaque. Maybe it was issues in communication from the patient, right? There was no clear policy for a clinician. Imagine a young clinician in training to overread or post-deployment monitoring. So the staff said when all this was brought about, again, based on real cases, said, well, actually, it was not vetted by leadership. It just hit it. So the fast lane bring us together to the model's knowledge that where it was generally available to the clinical population. So the question that we should ask, right? Doing governing, what should we ask before deployment in a clinical setting? how clinicians maintain judgment and challenges the outputs in a high-pressure environment where governance structures are needed to ensure these tools are safe, equitable, and contestable. So to conclude, AI is obviously transforming medicine. So that's not the question. The question is how medicine can humanize AI. So I want to flip it. I'm not going to keep saying this sensationally that said AI is going to dehumanize medicine. I'm really going to prompt it, how do we do better? So one is in the practical framework of knowing, doing, governing, how we keep validating and making explainable. Accurate for whom? And the ethics of doing is human-led, it's about choices, right? Contest authority of the tool. And governance, how AI reshape the system. So at the end, what I will say is in system implementation, in AI implementation, and the scientific judgment pass on the technical judgments and validations of these tools, don't forget ethical competences. Don't forget about it. And with that, I really want to thank you for your attention. Thank you. And invite any questions or comments. You can push back.
Thank you very, very much for this intriguing and important lecture, and very timely, I must add. Maybe I'll begin by asking the first question. So practically speaking, ultimately, it's the physician who's signing the chart who's making the decision, right?
Yes.
And there's no substitute for that, whether it's the Cecil textbook of medicine, up to date, Harrison's, whatever it is that they're reading, whether it's open evidence or any of the other ChatGPT AIs, it's still the physician that is synthesizing the information and not automatically presenting it to the patient. So things have changed a little bit for the better, I think a lot for the better in terms of having lots of knowledge at our hand, albeit textbooks are biased. There's bias. And I know this is more of a lecture than a question. So, but my question really is, what sort of practical governance structure do you recommend Academic Health Center institute for the use of AI? What should we be doing that we're not doing now? Practically.
Yes, and very practically is first go and say, the tool that you bought, this AI system, fancy or not, well then, how was validated? Science, evidence, how it was validated. If it works for our system, and importantly, when you implement it, and Dr. Way said rightly, it's human choice, it's the responsibility of the doctors. It said, what happens if we realize that it's not working well? I think that's the most practical advice. When we talk about governance and accountability, it seems very abstract. In practical terms, do I have a way to contest it? Do I have a way to say, even to leadership, this is not working well for this population. How can we fine tune? How can we improve it?
So we have multiple, just to answer your question, what we have here is we've instituted 2 AI scribe situations that we're testing currently and getting feedback on, and they were vetted before we chose them among all the others in the land. And we have constantly working with Copilot, which is the official approved HIPAA compliant AI form that we use. But Dr. Colbert, you have a question.
Yes, hi, thank you very much.
It's on.
Okay, I trust. Okay. So I did one of the things.
What's the tool?
So in medicine today, we have some problems in terms of the ability to get people into care. Access to care is an issue, follow-up especially. So wouldn't you view AI as an opportunity here to improve how we have access to care, even though it may have some issues that you've discussed?
Oh, absolutely. And to be fair, I said this is practical, in some levels theoretical, and it doesn't mean a judgment to how our institutions do. Absolutely. It should be a tool to improve care. How can you improve? One of the examples that it was of how we triage patients and how we assess so others access to care by social determinants. The case about the late appointments is not from here. It's a colleague that works in a different healthcare system in the US told me that this was brought to the AI Healthcare Committee. She's an ethicist like me, and she was part of that panel that assessed when they look at the zip code. Absolutely, Chulo Healthcare. And Dr. Weiss, to your comments on the scribe, yes, when I have been with my family doctor and she used the AI scribe, it was fantastic. We even talked and said, look what it wrote. What do you think? And then she started adding some nuances, knowing the patient.
Dr. Sosa.
Thank you very much. I have a question with regards to patient-informed consent and the utilization of AI. We have, as Dr. Weiss mentioned, several AI tools to assist us with answering messages in our Epic chat. But in addition, when patients come and we use Ambience AI, we obtain verbal consent. I wonder where is the standard of care that verbal consent interrupts workflow, and it has to be obtained if you have a busy clinic 13 times and it prompts questions. Are there more efficient ways with regards to obtaining informed consent at the time of utilization of Ambience Scribe?
Oh, that's a hard question. So there's always ways to probably make informed consent more efficient, and that will depend on the particular setting. So maybe there's a way to include it in the general consent for care, a line that it states that certain AI tools will do, and then a brief consent the same way you provide consent very in a natural, organic way when you see a patient. So, but it will be above my pay grade with risk to see how it could be implemented. To be fair, when I have seen it, and that's my bias, when I have seen here, the consent will be, unless somebody got nervous because they knew I was the ethics person here and it was a junior doctor, order to have been very quick to say, hey, by the way, I'm using this to, I'm using my scribes, I'm using algorithm, or even to look at medicine. I remember some doctors said, oh, let's ask Dr. Copilot. And then with me, they work to that. So yes, it might take more time, but time is important. But if you're going to balance time, consent should reserve attention. But there should be ways to streamline it. And maybe that's an action point, where in the whole chains of documents of consent forms, the patient signs. And never mind that we still sign when you go to practice less now. The patient goes and the screen is looking at the person here, and they said, sign the consent. You're signing this. So I'm always the fastidious that said, can I see what I'm signing?
Dr. Mendel.
Thank you. At the risk of sounding like a Luddite, at age 90, I've been 70 years in medicine, started at age 20. The system, if the system is not broke, we're not supposed to fix it. Why do we use AI in the first place?
If the system is not broke, what we need to fix it? I would say the system is a bit broken. But maybe generalizing that not everybody receives the care they need in the best way they have. Maybe not here. I come from Canada when I lived over 20 years, and I can tell you how broken healthcare was, how poorly it was administered, with doctors with the best intention who deliver very poor care. So not everybody is the same, but in some cases, the system is broken when not everybody have access. And with access is fractured and depends on how big your insurance is. But I do agree, a technological fix is not always the best solution or the solution you need. It's about other systemic issues.
Okay, Mr. Balos, medical student.
Hello, good morning. Perhaps across imaging modalities, X-ray, CT, and MRI, it has been proven AI has, with more specificity, predicted the pathology across all modalities. Now, better than human
Yeah.
providers. With this understanding and the points that you brought up, the challenge of integration between provider and AI. And the pitfalls, this one can happen with the predictability of diagnosis and misdiagnosis. Would you propose that the optimal way to move forward is to reduce the applicability of AI only to prognostication of diagnosis and imaging modality,
Yep.
and remain clinical reasoning and things of this thing with physician? Would you propose this one is the optimal way forward?
I think you say it. Is that proportional balance, right? Tools are aids, and the tool is performing well, is fantastic. We just don't let replace professional judgment. And that's your experience, that's your knowledge, that's your evidence. If it's working and it's a tool that helps even catch errors, is fine. So the best approach is that proportional approach. One doesn't substitute the others. And also Dr. Mandel would say, if the system is no broken there, why you need to fix it.
Thank you, Dr. Isasi, for very interesting grand rounds. We appreciate your lecture and all the information that you provided to us. I want to remind everybody to check the QR code as you depart from the lecture hall to get your MEC and MOC credit. And those online, you can check the chat. I look forward to seeing everybody next week, and take care of yourselves and each other. Oh, next week is Research Day. Be there or be square, but it's also, we have a lecture at this time as well on the third floor, but we have posters and it's a whole celebration. Be there.